Good morning, everybody. I am Dr. Alaa Zawawi, Professor of Ophthalmology, Alexandria University. I will be giving you today the lecture of errors of refraction. It is divided into two parts. First part is myopia and hypermetropia, and the second part astigmatism, presbyopia, and isometropia. The most important for me today is that after these two lectures we will be understanding what is the meaning of errors of refraction, why there is myopia, what is hypermetropia, what is the treatment of myopia, what is the treatment of astigmatism, and also common questions. Glasses are to conserve the sight? Are glasses, what are glasses worn for? And the safety of refractive surgeries. These are questions in all society, and you have to understand in order that you will be able to answer these questions. We will start today by errors of refraction, and I will start by what is the meaning of emmetropic eye. Emmetropic eye is the normal eye. Normal eye means that the rays coming from far away, from the infinity, are capable of being focused in a point on the retina, and these are refracted by the cornea and the lens. What is refraction? Refraction is the bending of the light when it passes from one medium to another medium of different curvature, and this refraction depends on the curvature of the media and also on what we call the refractive index. What is the refractive index? Is the density of this tissue, meaning that if you have rays passing from the air to the glass or to the cornea is more dense than air. That's why the speed of light will be slowing a little bit inside the cornea and slowing once more inside the lens. This slowing is causing bending of this light, and this is what we call refraction. The rays coming from infinity are refracted by the cornea and lens, and these are the main refractive media of the eye in order to be focused in a point on the fovea, which is the most sensitive point of the retina. Let us see what are the factors in this refraction. You will see that the most important factor is the anteroposterior diameter of the eye. This is the main player, playing the most important role in errors of refraction, meaning that if this axial lens or the lens of the eye is normal, the rays will be focused on the macula. But if the eye is longer than usual, these rays will be in front of the retina, and this is the condition of myopia. On contrary, if this eye is smaller in size, these rays will be focused behind the retina, and this is the condition of hypermetropia, meaning that the main player is the axial lens. And what is deciding the axial lens? Mainly genetic factors. There is racial factors, yes, but it is not decided by I am reading more, I am not using my glasses, I am reading in dim light, I am reading a lot, I am on the computer too much, on the mobile too much. No, it's only the axial lens of the eye. Also, the most important is the cornea and the lens, and in the cornea and the lens, two issues: the curvature and the refractive index. We will see now in the following slides what does this mean. Refraction of the eye is affected mainly by the axial lens, which is normally 23.5 millimeter, and less by the power of the cornea and lens, and in each of these we'll speak about curvature and refractive index. This is a case where the cornea is more refractive than this one. This is a normal cornea. This mainly is a keratoconic cornea in which the curvature is more, and it will induce some myopia. But the main cause of myopia is this one, the axial myopia. What is axial myopia? Is increase in the length of the eyeball. You know the story? The story that every child is usually born with a small eye globe, like small hand, small arm, small foot, and also the eyeball is small. Most of the children, more than 99% of the children, are hypermetrope when they are born. Why? Because they have small globes. This globe will increase in size and it will reach its normal size by the age of 5. And this is the normal site that the rays will be focused on the retina. In 40% maybe, and there is difference among communities and ethnic factor, the eyeball will grow further, like this ball. It will not stop here, but it will grow like that. And the rays will be focused in front of the retina, and this is the main issue. And this will be the condition of myopia. This is emmetropia. What is emmetropia? Parallel rays with accommodation completely relaxed come to a point focus on the retina. What I have said, with accommodation completely relaxed. What is accommodation? We have seen that in the physiology at the beginning of our career in the Faculty of Medicine. Accommodation is the ability of the lens to change its power. To change its power by, if you are seeing a near object, the lens will become more convex. Far object, the lens will relax and to become more flat. This is coming through the action of the ciliary body, and it needs a certain elasticity of the lens. This elasticity is lost all over the years. From the start, since we are born, the accommodation is less and less and less. It reaches 14 diopters while we are young, by the age of 7 maybe, and it decreases to be 0 by the age of 16 maybe. This is the accommodative amplitude. This is the ability of the lens to accommodate. Here in the errors of refraction, you must say with accommodation completely relaxed, because think of it, if the lens is more convex, it will be more powerful because this curvature has increased, and the rays, instead of coming here, they will be coming in front of the retina, and this is condition of myopia. This is due to spasm or ciliary body spasm and inducing more accommodation of the lens. Emmetropia, that condition of refraction in which, with accommodation completely relaxed, parallel rays come to a point focus on the retina and we are seeing everything. This is the emmetropic eye, and this is the power of the cornea, the power of the lens, and it is in diopter. What is a diopter? The diopter is the unit to measure the refraction, and the power of any, in secondary school you have taken this, it's 1 over the focal length of this lens, meaning that a lens of 1 diopter, it will bring the focus on at 1 meter. A lens of 4 diopter, 100 over 4, will be the focal length 25 centimeters. A lens of 10 diopters, 100 over 10, it will be the focal length 10 centimeters. The eye is 60 diopters. This is too much, subhanallah. 42, about 42, 43, 44, sometimes more, sometimes less, is coming from the cornea, because this is the main refractive surface. It is the first surface that the light will come in entering the eye, and also because of the curvature of this cornea. And second is the lens, which is 18 diopters. The sum is about 60 diopters, and the rays will come in focus on the retina. This is not 42 can be 40, can be 39, and 18 can be 20, can be 21. But this is the main refractive surface of the eye. As we said before, the main player is, beside this refraction, but more important, is the axial lens, which is the anteroposterior diameter of the eye, and this is the main deciding factor why there is people hypermetrope, why there is people myope. Astigmatism is another issue regarding the curvature of the cornea, as we will see in the lecture of the astigmatism. Punctum remotum. What is punctum remotum? From its name, it's the furthest point that this eye can see. What is its importance? To understand how to calculate the near point and the far point of the eye. Let us see. The frontal remotum of the emmetropic eye is, how to get it? Parallel rays coming through the cornea and lens are coming here on the retina. In order to get the punctum remotum, get the reverse of the rays. Meaning what? Get a point over the retina, let it be out through this diopteric system. Diopteric system is the system through which the light will pass. And let us see where it will go. We have what we call reciprocability of the light, meaning that light coming from infinity, focusing on this point. If you have the light originating from this point, it will go outside this diopteric system at infinity. Infinity is the punctum remotum of the emmetropic eye. That's why when we see away, we can see the aeroplane, the ship, anything far away. Infinity is the punctum remotum. Remember how we are getting the punctum remotum. Get a point on the retina, get it out through this diopteric system, which is here normal. Meaning normal what? That the axial lens is 23.5, for example, and the lens and cornea exactly the power that will bring these rays on the retina. Get a light from the retina, it will go at infinity. This how to decide the punctum remotum. We will apply it in myopia, we will apply it in hypermetropia, and we will see what will happen. What is ametropia? The errors of refraction. State of refraction of the eye in which, and we will say the phrase, the usual one, with accommodation relaxed. Accommodation must not interfere here. Parallel rays do not come to a point focus on the retina. We have seen the metropia coming in a point of the retina. If they don't come in a focus on the retina, these are the errors of refraction. There are three: myopia, hypermetropia, astigmatism. Okay, but in the book there is something else, presbyopia. This is an issue that we will speak in the next lecture. Ametropia, errors of refraction are myopia, hypermetropia, and astigmatism. What is myopia? Myopia, by definition, that condition of refraction in which, with accommodation completely relaxed, the usual phrase, parallel rays come to a point focus in front of the retina. This is myopia. Let us think about what is the cause. Mainly the axial length of the eye, that this eye has grown above the limit of the normal eye. Due to what? Usually genetic factors. Do you have something to stop this? No. Do you have something up till now, up to the end of 2022 now, to stop this process or to modify this process? There is so many studies, but nothing is definite up till now, and it's the natural course. Myopia, that condition of refraction in which, with accommodation completely relaxed, parallel rays come to a point focus in front of the retina. Let us think. We have seen the main player is the axial lens. Also, there is other factors in the cornea and in the lens. If the cornea is more steep, more curved, this will end in myopia. If the lens is more spherical, this will also cause myopia. These are the causes of myopia. Myopia, that condition of refraction in which parallel rays come through this diopteric system in front of the retina. That's why we are correcting it with concave lenses. Why? In order that these lenses will diffract the light, that it will let the light more diffracted here, in order that it will be more convergent here, and it will come in a point focus on the macula. Let us see. The diopteric system of the myopic eye consists of the cornea and the lens. Is it more powerful than normal or less powerful than normal? The rays are coming in front of the retina, meaning that this diopteric system is in the myopia more powerful than normal. It should come here, but it came here, meaning that this combination is more powerful than it should be. يبقى the diopteric system in the myopic eye is more powerful than needed. Punctum remotum. We have seen in the emmetropia how to get the punctum remotum. Punctum remotum, you are getting a point from the retina, getting it out through this diopteric system and see where it will go. We have just told that this diopteric system is more powerful, more converging the light than normal. If you get this ray from here, out of the eye, out of this diopteric system consisting of the lens and cornea, which is more powerful than usual, it will come in a point focus not in emmetropia, but in front of the eye at a variable distance according to this lens, according to the power of this eye. Let us take an example. An eye myopia minus 4, meaning what? 100/4, that the focal length is at 25 centimeters. That the punctum remotum is at 25 centimeters. Let us think. If you get a book or anything to read or to see at 25 centimeters, this eye will see it perfectly or not? Of course, yes. Because this eye is at the punctum remotum. It will be exactly here. The rays will go here and will come focus on the retina and this eye, and that's why myopes minus 4, for example, if they will put the book at 25 centimeters, they will see it perfectly without any accommodation. And this is some advantage of the myopic people. They read more easily than hypermetropia and emmetropia. Etiology. Let's one ask himself, or why I am myope? Why this guy is myope? Why not emmetrope? Let us see. Etiology is mainly axial. Mainly axial. Increase in the axial length. As this is the most common, and each 1 millimeter is inducing 2.5 diopters of myopia. Each 1 millimeter increase in length, it will induce myopia 2.5 diopter. And less refractive. Yani the main factor is axial, and the second factor is refractive. Refractive, you speak at the start of the lecture about curvature and index. Curvature, two factors, cornea and lens. The cornea being more curved like in keratoconus, and the lens more curved like in lenticonus, it will induce more convergence of the light and introduce myopia. Refractive index of the cornea, it doesn't change. No disease is changing the refractive index of the cornea, but the lens, yes. Uncontrolled diabetes and early cataract are changing the refraction of the lens. This is important clinically, because if you see an adult with a recent onset of myopia after 20 years of age, مثلا at 40, at 50, what is this? We have said that the main factor is the axial lens. That the eye increase in length after the age of 20? Usually not. You are not increasing in size after the age of 20. The same for the eye. And that's why we are waiting till the age of 18, 19, 20, till the eye will stabilize in order to do any refractive surgery, LASIK or any refractive surgery. This is the cause. If you are seeing somebody at 50 years of age and with a recent onset of myopia, think about two issues: uncontrolled diabetes and early cataract. I have written anterior dislocation of the lens, which is very rare, but actually if you think about it, this lens, if it will move forward, it will be more powerful and it will induce myopia. If it will go backward, it will induce hypermetropia. But this is rare. The main issue are these two factors, and the main is the axial lens. Let us see the symptoms. The only symptom for myope, I am not seeing far well. This is usual. In very high myopia also there is floaters, which is called musca volitans, or defective night vision also for high myopes. But the only complaint of a myope is I cannot see far well. There is no headache in simple myopia. There is no pain in simple myopia. Only he is not seeing far well. This is an example of an emmetropic eye, and this is myopia, for example, of 1 diopter, 2 and 3, and there is deterioration of vision. We must speak about two types of myopia: the simple myopia and the pathological myopia. Simple myopia is the most common, and the age, it starts by the age of 10, 11, 12 at puberty, because the body will grow maximum at this age. Also the eye is growing maximum at this age, and it will continue to change till the age of 18 up to 20. And that's why we are speaking about the term of school myopia. It happens during the school age. It doesn't exceed 6 diopters, from -1, 2, 3, 4 up to -6. The eye is completely normal. It's only a little bit more in the axial lens. There is no complications in simple myopia. But on the other hand, we have the other issue of progressive myopia, the high myopia, the degenerative myopia, or malignant myopia. Why these terms? Because they may be associated with complications. It starts earlier than 12 years and progress with age, and this may progress after the age of 20. But it slows down after the age of 20, but it may progress after the age of. That's why people maybe 23, 24, if they have high error, -6, -7, they are continuing to change their glasses. A may reach high numbers, 20, 25 diopters. The eye is large, the cornea is large, the anterior chamber is deep, the pupil is, everything is large, and the fundus shows what we call temporal crescent and myopic fundus with tigroid background. Complications, they are only happening in high myopia. They don't happen in the simple myopia. And mainly, as you are seeing here, they are retinal in the posterior segment, not in the anterior segment. That is only the lens which is posterior subcapsular cataract, and there is an apparent convergent squint, not a real squint actually. But the main complications are in the posterior segment. Why? Because this part of the eye is the one stretched in high myopia. The anterior part of the eye, almost the same. The cornea, the lens, up till the lens, it's almost the same. But the posterior part is increasing in size, and that's why it induces chorioretinal degenerations, retinal tears, retinal detachment, macular hemorrhage, what we call Fuchs spot. All these complications are happening because of the stretching of the globe. This is what we call high myopia. This is what we call scleral crescent. As you are seeing, this is the tigroid fundus, which is mottling of the retinal pigment epithelium, lighter in color and darker in color. And here there is a complication, which is a macular scar, what we call at one time Fuchs spot. Fuchs spot is subretinal neovascularization due to high myopia and inducing a scar in the macular area. This is another case of high myopia with what we call scleral crescent, stretching of the posterior pole and hemorrhage in the macular area. What is the treatment of myopia? Usually more than 90% or more, glasses. Glasses are known since very long time, more than 150 or 200 years. And here we are using the concave glass minus lenses. Why? In order that to induce divergence of these rays, because this eye, we have told in the lecture that they have a more powerful optical system. That's why you have to diverge these rays in a manner that this diopter system will bring this in focus on the retina. Minus glasses or concave glasses are used to correct myopia. Contact lenses, of course, can be used. What are the advantages? 3 advantages: cosmetically better, no magnification, and wide field of vision. Wide field of vision because the glasses are restricting the field by the frame. But contact lens, being in touch with the cornea, they have a wider field of vision. That's why in sports, for example, in basket, handball, tennis, everything, it's much better to use contact lenses because it's freedom from the glasses. Surgical treatment, yes. We have the radial keratotomy at one time, but we stopped it actually, and that's why we will not speak a lot about it. And the laser. The laser is used to correct this error of refraction, and we are waiting till this eye will stop growing, maybe 18, 19, 20 or over, and we are allowed then to do surgical correction by laser for this error of refraction after being sure that everything is correct, mainly in the cornea. We have to study the corneal thickness and the corneal topography in order to exclude any abnormality in this cornea, any keratoconus or possibility of keratoconus, and it can be done this. We have types of laser. Mainly we have the surface laser, which is the PRK, photorefractive keratotomy, and we have the LASIK, which is laser under a flap. These are the glasses, and these are the view through the glasses. You are seeing better but smaller, and this is what we call minification of the effect of glasses. This minification is not found in contact lenses, is not found after laser. That's why the view or the quality of vision after contact lenses, with contact lenses and after laser, it's better than the glasses. This is the view sees through a minus or concave glasses. What are the types of glasses or lenses used in glasses? We have the spherical lens, convex and concave. Concave used to correct myopia, convex used to correct hypermetropia. Cylindrical lenses, as we will see now, are in the second lecture to correct astigmatism. These are the plus lenses. These are used to correct hypermetropia. These are the minus lenses used to correct myopia. These are the cylindrical lenses used to correct the astigmatism. Types of lenses, different type of lenses used in glasses. These are the contact lenses which has some advantage, but also they have their complications because they are foreign body, and the abuse of contact lenses is known to induce maybe infection, maybe corneal ulcer, hypoxia of the cornea. If used properly, it's okay, but if used not properly, they are foreign bodies. They may induce complications. These are the radial keratotomy that were used at one time to correct myopia, what we call in Arabic al-tashrit. This was used since more than 20 years. Nowadays it's obsolete, and the idea was to create deep cuts in the periphery of the cornea to induce flattening of the center of the cornea. It's used to it was okay at that time, but there is complication that this effect is progressive, and these patients, we are seeing them nowadays with hypermetropic astigmatism. That's why we almost all have stopped using this radial keratotomy. And this is the LASIK to induce a flap of the cornea to correct myopia by this profile, to correct hypermetropia by using the laser to remove tissues from the periphery, and to correct astigmatism also. We are creating a flap. The excimer laser will ablate or remove tissue from the cornea, and we are returning the flap again. The safety of the LASIK must be in the range of 99%. Nothing is 100%. This is the laser, and this is the surface ablation. But if you are ablating the surface, this is the issue. And each type has advantages and disadvantages, and this is not the scope of our lecture today. This is the excimer laser. Okay, let's go to the other side of midnight, hypermetropia. What is hypermetropia? Hypermetropia is, by definition, that condition of refraction in which, with accommodation completely relaxed, parallel rays come to a point focus behind the retina. Yani rays coming from infinity through the dioptric system of the eye are coming behind the retina. Let's think in the same manner that we thought about myopia. What is the main factor is the axial length of this globe. That the globe is small inside. It stopped at the infantile age, like it stopped while it is small. What is the cause? Also genetic. It is not acquired. Genes are playing the major role here. And the dioptric system of this eye is more powerful than normal or less powerful than normal? Of course, less powerful than normal, because the rays are coming behind the retina. But in young age, children, and your age, the 20s, and up to 30, and maybe early 40, we have the ability of accommodation, the ability to increase the refractive power of this lens, and you may not feeling it. You might be having some hypermetropia and not feeling at this age, young age, because the lens will correct this error by the accommodation. But if this error is high and the lens is accommodating too much, what will happen? Symptoms will happen, as we will see now. This is hypermetropia, condition of refraction in which parallel rays with accommodation completely relaxed parallel come to a point focus behind the retina and corrected by plus lenses. Contrary to the myopia, coming in front of the eye and corrected by a minus lens. Consider this eye is short and this eye is long. Punctum remotum. In order to understand where are the rays going to be formed in hypermetropia, we thought in emmetropia, in myopia, and also in hypermetropia, how to get the punctum remotum. Get a point on the retina, get it out of this eye, and look where they will go. Okay, we have spoken in this hypermetropia that the diopteric system is less powerful than normal. Being less powerful, let us see, if you get a point from the retina out of this less powerful, they will be going divergent, and as if coming from a point behind the retina. We have seen in emmetropia that if you put something in the far point, you will be seeing it clearly. Also in myopia, there is a distance that you will put something that you will read clearly. Hereby in hypermetropia, without accommodation, can you put something behind your head or behind the eye to read it? It's impossible. That's why hypermetropic error is more symptomatic than myopia. People are saying أنا عندي بعد نظر زي الفل. No, hypermetropia is, there is complaints much more than myopia. The only complaint in myopia is I cannot see far well. In hypermetropia there is headache, there is athenopia. What is athenopia? Athenopia is إجهاد العين. Athenopia is that condition in which we are tired, the eye are exhausted, there is pain in the ciliary body, there is some headache, there is redness of the eye, watering of the eye, you want to sleep. This is إجهاد العين. What is the etiology? Axial also, small axial lens, each millimeter is inducing 2.5 diopters of error, and refractive, and we have spoken that this refraction is less than needed. Curvature in flat cornea, index, decreased refractive index of the lens. It doesn't happen except at the start of treatment of diabetes. At the start of treatment of diabetes, the lens becoming more flat, inducing some hypermetropy. And this third issue, yes, you can omit it, meaning that the lens, if they are posteriorly displaced, which is extremely rare, they are less effective, as we have seen. Symptoms, mostly no symptoms. No symptoms? Yes, mostly no symptoms. All children are hypermetrope. Maybe among you in your age, in the 20th, hypermetrope without any symptom. How? They can see 6/6. How? Through accommodation. The lens in the eye will do the function of the glasses, meaning that they become more convex and there will be no symptoms. There can be symptoms, of course, if hypermetropia is too much and there is accommodation too much. We are speaking about accommodative athenopia to start with near and then for far. Why for near? Let us see. If I am an emmetrope at your age, meaning that at infinity the parallel rays are coming to open focus on the retina. If I am putting something to read at 33 centimeter, as we are recommending, for example, what the lens will do? My lens will do accommodation. It will increase its power by how much? 100 over 33, 3 diopters. If I will hold this book at 25 centimeter, the lens will induce what? 100 over 25, 4 diopters of accommodation. That's why we are telling you, read at a further distance. This will be less exhausting to your eye. If you are bringing things nearer, you are exhausting your eye more because you are inducing more accommodation. This is an emmetropia. Let us think about hypermetropia. Hypermetropia meaning what? Meaning at far distance, while the emmetropia is not inducing any accommodation, the hypermetrope may be doing, for example, 1 diopter of accommodation. He's seeing perfect, 6/6. By the way, 6/6 does not mean that he doesn't have an error of refraction. You may be 6/6 and having an error of refraction, like hypermetropia. Far away, he is doing 1 diopter of hypermetropia. let him to read or to study at 33 centimeter, he must do an extra 3 diopters. Already he is doing 1 diopter. This hypermetrope is doing 4 diopters to study, while the emmetrope is doing 3 diopters. And the myope, -3 for example, he is not doing any accommodation. That's why a myope of -3 in studying without glasses, he may be studying without any effort. And that's why there is more myopes among the medical students. This is the cause, not the contrary. Hypermetrope, there is difficulty in reading. That's why there is accommodative apsenopia for near to start with, and then also for far when he is getting older and older. By the age of 36, 37, there will be early presbyopia. What is presbyopia? That the things nearer will not be properly focused, and he has to hold things further away. This usually happens in metrope by 40s, by the 40, 41, 42. In hypermetropes earlier, it can be 35, 36. In myopes later. And finally, also defective far vision. By the age of 60, 65, 70, he cannot do any accommodation, and he cannot do the 1 diopter that he was doing while he is young, and that's why there is diminution of vision. This is the sequence of the symptoms. What is sequence? That in young age there is no symptoms. In the early 20 something, headache while near, more after 5 years, headache on far, and then early presbyopia, 35, 37, and then also by the 50 or 60 far away. These are the sequence of what happens for a hypermetropic patient. Signs, usually there is no signs. You cannot define the hypermetropic eye while just looking to their eyes. You can only in high degrees, small eye, small in everything, small cornea, shallow anterior chamber, what is called pseudoneuritis, and these are the components of hypermetropia. They are not written in the new book, meaning that total hypermetropia, that one measured under the effect of atropine or psychoplegic, it is composed of latent and manifest. Latent is that tone of the ciliary body. Manifest is facultative and absolute. Facultative is that part of hypermetropia corrected by accommodation, as we have seen now, and absolute, that part of hypermetropia not corrected by accommodation. The story that while we are young, all the hypermetropia are corrected and are facultative. When we are getting older, some of the facultative are changing to absolute, and there is diminution of vision. With more age, more facultative are going to absolute, and finally by the age of 60 or all the hypermetropia are absolute. Complications predisposing to narrow angle glaucoma. Narrow angle glaucoma doesn't happen except in hypermetrope with small eyes and shallow anterior chamber, and that's why inducing angle closure. Squint. Hypermetropia is the main cause of convergent or esotropia in children due to the accommodation. Accommodation is bringing with convergence, and this convergence, when it is in extra amount, it can induce esotropia due to this, and this will be spoken about in the lecture of squint, of course. Treatment, small error, no complaint, no treatment, because any child, he must wear glasses. There is no symptoms, no aphanopia, no headache, seeing 6/6, no glasses. This is the majority. All children are hypermetrope. But when there is symptoms like headache, aphanopia, yes, you have to treat. With what? With glasses, mainly convex glasses, in order to do the job. These plus lenses are bringing the far point behind the retina on the retina, and relaxing accommodation. This is the main issue. Relaxing accommodation. Symptoms will disappear. There will be no aphanopia, no headache, and he will be happy. Contact lenses with the same principles like myopia. Also, they are foreign bodies, but they have wider field and cosmetically better. Surgical treatment in hypermetropia is less effective than myopia. Basic And laser treatment is less effective in hypermetropia than myopia. Why? There is regression in hypermetropia and the error will happen again, and that's why we are not welcoming to treat hypermetropia by LASIK in the high errors, +4, 5, 6, usually they are returning back. There is so many things to be, but this is not our issue today, but it is less effective in hypermetropia than in myopia. Thank you very much. This will be the end of our first lecture, and we will get together by astigmatism and presbyopia in the last lecture. Thank you very much.